Okay, welcome everyone. It is 11 a.m. Eastern, so we'll get started here. My name is Ben Adam. I'm a renal pathologist at the University of Alberta Hospital in Edmonton, Canada. And on behalf of the Renal Pathology Society, it is my great honor to welcome you to the second session in our latest webinar series focused on focal segmental glomerulosclerosis and APOL-1 nephropathies. As I mentioned at our first session a few weeks ago, our understanding of these diseases has rapidly expanded in recent years, and these new insights have significant implications for renal pathologists, nephrologists, and patients with kidney disease. And so the intent of this webinar series is to provide a cutting-edge update on these important topics to our colleagues and partners around the world. I would like to acknowledge that this series is supported by an educational grant from Vertex Pharmaceuticals, and we're very grateful for their support. A few quick housekeeping items before I introduce our speaker for today. First, we have made arrangements for live interpretation of the session into Spanish, so please be sure to select that language option within the Zoom controls if you wish. Second, we will have time for a short question and answer session following the presentation, so please enter your questions into the Q&A section and we will do our best to address as many of those as we can. And finally, you'll be asked to complete a brief survey at the end of the webinar, so please take a minute or two to fill this out, as this feedback is very important for planning future sessions. So without further ado, it is my great pleasure to introduce today's speaker, Dr. Jeffrey Kopp, who will be providing an update on APOL-1 nephropathies. So Dr. Kopp graduated from Harvard College and the University of Pennsylvania School of Medicine. He completed internship and residency in internal medicine, as well as nephrology fellowship at the University of Washington. Since 1987, he has been at the National Institutes of Health, currently serving as chief of the kidney disease section for the NIDDK. He leads a translational research group studying mechanisms of and therapies for the syndrome of focal segmental glomerulosclerosis, with a particular focus on the role of APOL-1 genetic variants. He served for 25 years in the United States Public Health Service with deployments to public health crises and retired with the rank of captain. So thank you very much for being with us here today, Dr. Kopp, and I will hand it over to you.
Thank you so much for that nice introduction, and thank you to the Renal Pathology Society, which I believe I'm a member of, if I keep paying my dues, that is, and for the opportunity to talk to you today. So the topic I've been asked to address is some material on Fsgs. I know that Astrid Wiens gave a nice talk recently on the pathology. So focusing here on therapy and on APOL-1, both with regards to Fsgs, but also other manifestations. Okay, so Fsgs can be classified in various ways. Many of us have our own approaches. The one that I like is to think of about Fsgs as syndromes as having 6 mechanistic groups. The most common are shown as the 3 biggest red clouds. Primary due to cytokine, various cytokines, I'll be talking about that, or immune activation, although we don't really understand all of it, and I'm sure there's lots more to be learned. And then post-adaptive Fsgs, the green cloud, representing a mismatch between glomerular load and glomerular capacity, leading to increased pressures within glomerular capillaries and glomerular damage. And then continuing around the circle, the third largest form is APOL-1 Fsgs that accounts for fully 72% of African Americans with Fsgs in this country. And the system of classification is not perfect, as you'll see, because APOL-1 can manifest as several other different types, for example, post-adaptive, medication-associated, and primary. So then the 3 smaller clouds represent Mendelian Fsgs, this yellow cloud. Now we have over 50 genes in which variants are associated with Fsgs, and the number continues to climb every year with the introduction of next generation sequencing. Viruses are involved in Fsgs, certainly HIV and CMV, and very possibly B19 and EBV. I've got the question marks here because I'm being a bit of a skeptic, but I think they may very well be involved. And then lastly, certain medications, as you'll see, some of these map back to other forms. So there's an overlap. Right off the bat, interferon seems to work by increasing APOL-1 expression, so it's also a subcategory of APOL-1 Fsgs. So first of all, primary Fsgs, the typical clinical phenotype. Individuals may have an acute onset, particularly in children, where the mother says, I know my child was normal when I put them to bed, and in the morning they had developed puffy eyes. But it certainly doesn't have to be acute, and in adults it tends to be more indolent. Typically, this involves high-grade proteinuria, passing the usual nephrotic syndrome definition of greater than 2 grams per gram, and often will have full-fledged nephrotic syndrome. As part of that, there will be low serum albumin, and this is the form that recurs or may recur, certainly does not always, following kidney transplant. Usually the recurrence happens within hours to days and manifests as primary FSGS. The renal pathology of primary FSGS, and again, you heard a lot about this from Dr. Wiens, is that it may take many forms, but particularly collapsing or the not otherwise specified. Widespread foot process effacement is typical, at least greater than 50%. And a subset of this is collapsing FSGS, or perhaps some have preferred the term collapsing glomerulopathy, as segmental scars may be absent. And the characteristic features here, as you know, are increased numbers of cells in the podocyte niche, that is either overlying the parietal epithelium or actually out in Bowman's space. And these are now believed to be parietal epithelial cells, or perhaps more accurately, their precursors. So standard and emerging therapy for primary FSGS, typically this responds to immunosuppressive therapy, even though this is not a classic immunologic disease, but the disease often relapses when therapy ends. The mechanisms of response are not well understood. Is it suppression of a circulating factor by steroids or a direct effect of podocytes? It may be some of both. Typically, patients are started on glucocorticoids unless there's a very sizable contraindication. For example, somebody with type 1 diabetes, this may not be a good choice, but barring such complications, typically people start daily prednisone, sometimes alternate day where there's some concern about side effects. And there are some studies suggesting that this may be efficacious, but it's not standard at this point. If patient has not received glucocorticoids or is glucocorticoid resistant, perhaps after an 8-week course, then typically the next choice is a calcineurin inhibitor, such as cyclosporin or tacrolimus. Again, there may be contraindications like low GFR that might make somebody reluctant to do this. And so, but typically then the next therapy would be mycophenolate. Here we do have a controlled trial, relatively few in this field of FSGS, unfortunately. The FSGS controlled trial enrolled 138 subjects, ages 2 to 40, and compared cyclosporin versus mycophenolate plus dexamethasone, and the outcomes were similar, suggesting either of these two approaches are fine. And because MMF plus dexamethasone had not been a standard therapy, that combination, many nephrologists would probably choose to use cyclosporin or MMF. Rituximab has gained quite a bit of interest. In that it is probably less toxic than a prolonged course of cyclosporin or mycophenolate. It may directly act on podocytes by binding this protein SMPDL3B, as suggested by Dr. Fernoni. Sorry, I left off a letter there, and the reference is listed there. Because CD20, the target of rituximab, is not expressed on podocytes, and this was an attempt to determine how rituximab might be beneficial. Another more recent therapy that's in development is Habitacep, a fusion protein of CTLA4 and the IgG1 Fc receptor that targets the co-stimulatory molecule CD80. This is approved for rheumatoid arthritis and has substantial efficacy across studies involving both MCD and FSGS. So one approach could potentially have the pathologist, when this question comes up, stain for CD80, and if in fact it's expressed in that case, recommend that Habitacep might be a fruitful choice, perhaps not as first-line therapy, but a second or third line. And then as a platform therapy, underlying all of these, and used exclusively as conservative therapy, would be the combination RAS antagonist, ACE or ARB, possibly combined. There is some evidence of increased toxicity by the combination, but I would argue that that combination, those studies were not done in this disease, and it may be possible to combine them, and a diuretic and a low sodium diet. And my preference is usually to use these medications at low dose and combine several of them, for example, thiazide at 50 milligrams a day, rather than what I had been originally taught way back in medical school is use a few drugs and use them at high dose. I now am tilting, and I think others are well, as combining lower doses of multi-medication. And I can't see what my final line is because this is blocking, sorry. So I wrote something, but I can't read it. Okay, well, it may have been about low salt and conservative therapy. I think that's what I was trying to say. When the GFR is low, particularly say less than 40, less than 30, one has to weigh what are we really going to benefit at the exposure of the toxicity of some of these medications. So these are selected trials that are currently ongoing or actually have been completed. The sparsentan study, which is a study of this endothelin blocker and angiotensin receptor 2 blocker, a combination 2-for-1 in this molecule, was completed. Unfortunately, there were very few complete remissions, and but the partial remission rate was 28% versus the control, which was 9%. So some benefit, but certainly not a home run. So there's a study that has recently been completed, probably involving primary FSGS, although it's hard to be sure, using CXA10, a fatty acid that upregulates nuclear receptor factor 1. It was a dose-ranging study, so not attempted to, not designed to establish efficacy, and we'll see, hopefully that program will go forward. There is an active, the next studies I'll be talking about are active. There's a study of this medication that targets the POTO or the ROBO pathway in FSGS. Pfizer is sponsoring that. And there is a study, there's a paper that I'm showing you about the background for choice of that pathway and the study design. There's a dose with this chemokine inhibitor, CXC140B is the name of the drug, led by Chemocentrics. That's an active study. There's an interesting study that uses LDL apheresis with the idea that LDL may be the site where some of these factors, both known and unknown, may reside, and an attempt to put patients into remission with that. There's an anti-CD20 antibody, different from rituximab, obinutuzumab, and that is an active study. And lastly, there's another study that targets an interesting pathway, P38 MAP kinase inhibitor, that's what that's supposed to say, losmapimod, and that has been completed, although there aren't full data at this point. So how about recurrent FSGS? Where do we stand on that? This is recurrence after transplant. Typically, it recurs within hours to days after transplant. If a patient has a rising creatinine 6 months or a year later, it probably doesn't fall into this category. The risk factors include childhood onset FSGS and particular histologies. For example, collapsing variant is more likely to be associated with recurrent FSGS and mesangial hypercellularity as well. And unfortunately, these individuals tend to have a rapid progression. Various molecules have been linked to recurrent FSGS. Jochen Reiser has championed SUPAR over many years, and that continues to be an active research interest of his. In fact, he's been developing and is now testing a binding column. I think it's a resin that can extract SUPAR from the blood, and we'll be interested to see what how that pans out. More recently, his group has talked about an interaction between SUPAR, APOL-1 risk variants, and the alpha V beta 3 integrins. So the story may be more complex, as these stories often are as the years go by. My group, working with Ginny Savin, has looked at cardiotrophin-like cytokine 1. We have a publication, but I think this is still early days in figuring out how broadly applicable elevation in this CLC molecule plays a role. In addition, there's been interest in antibodies in patients with nephrotic syndrome, including FSGS, to a variety of podocyte proteins, as you can see there. So how this might act in terms of pathogenesis and its frequency, I think, is still being clarified. So here I'd like to describe a small recurrent FSGS study that I came across that I thought was interesting. 7 patients with recurrent FSGS. And this group used plasma exchange with what they call semi-specific immunoabsorption using globofin columns as in globbing on to or having affinity for IgG, that uses a synthetic peptide ligands to bind particular regions of the Fc portion of IgG, subclasses 1, 2, and 4. So again, a way to clear immunoglobulin. After 1 year of therapy, mean proteinuria was reduced from 3 grams to 1 gram, which is a substantial remission and has going from full-blown nephrotic syndrome to partial remission, which has favorable long-term outcome benefits. But clearly more long-term data will be needed in larger cohorts. And I think most of us would have to acknowledge recurrent FSGS following transplant is a difficult problem, and our usual present therapies are not consistently effective. So certainly an appealing problem for somebody with a young nephrology colleague interested in tackling with these days of proteomics and so forth. This is a chance to make progress. So here are some recent treatment studies showing the increased interest in this area. First, the FUN study, an academic study led by Howard Trackman that looked at compared used adalimumab and rosiglitazone, which are TNF-alpha and PPAR, or TNF-alpha antagonist, a PPAR gamma agonist, and it was completed. It was certainly shown to be safe, and I'm hoping that that project will move forward, although I haven't seen anything. Another is a study that uses plasmapheresis and rituximab, targeting the podocyte. It uses intervention and control. It's a phase 3 study sponsored by the Department of Defense in its FSGS program that they advertised a couple of years ago, and it's encouraging to see that moving forward. The FSGS controlled trial that was published 10 years ago compared cyclosporin versus a combination of mycophenolate and dexamethasone. These agents are believed to target the podocyte. This was a phase 3 RCT, and there were similar outcomes with either regimen, suggesting that one could choose based on the toxicity that the patient might be expected to have or could best tolerate. And then lastly, there's this very small study of 7 subjects, but I list here because it's interesting, using this globofin column that I mentioned that binds immunoglobulin to remove the plasma factor. And the results are somewhat mixed in the publication that I showed you. And as I say, it is only 7 subjects, but hopefully this will be further developed. So we've been talking about primary FSGS. I'd like to shift now to post-adaptive FSGS, sometimes called adaptive FSGS, but it isn't really a good feature, so I prefer the post-adaptive FSGS. As you know, the clinical phenotype is that many of these patients will have subnephrotic proteinuria. Edema is often lacking, and they may have a history of premature birth or being small for gestational age, as you know, resulting in fewer nephrons because nephrogenesis halts when the child is born. The pathologic features are large glomeruli. Scars tend to be in the perihilar region, and the mechanism may respond to issues in the glomerular arterioles. And I wish I could get rid of my
looks like you.
Yeah. Yep, sorry, I was trying to change this banner at the bottom, but I failed. Okay, so therapy for post-adaptive FSGS, the second major class we'll be talking about. It typically responds well to what I call purposely being contradictory, aggressive conservative therapy. So an ACE or an ARB, possibly combined. There was a study, not in FSGS, that suggested increased toxicity with the combination, but I think potentially could be used. A diuretic with thiazide preferred, although loop diuretics if needed for edema. Dietary sodium restriction, not easy to do in our society, but this clearly potentiates the anti-diuretic effect of thiazide. So getting down below 2 grams a day is almost a must, and some patients can get down to less than 1 gram a day, but it does mean foregoing all sorts of prepared foods that we all love, frozen dinners, soups, and so forth, certainly meals out. Except as a treat. And not every patient is willing to do that or can do it. All right, weight loss if obese, stop androgen use, because there is this story where individuals were taking androgen to build muscle, and that increases glomerular filtration rate, and so it causes a post-adaptive FSGS, and getting those individuals to stop the androgens is important. Okay, so we've talked about three forms: primary, post-adaptive. This is now the third of the most common three, high penetrance genetic FSGS. I've used this term because we'll be talking about APOL-1, which is a low penetrance genetic form, and so this distinguishes this from APOL-1. Over 50 genes have variants associated with FSGS, and as I say, with the advent of next generation sequencing, we're seeing the number climb by several each year. Genetic cause is more likely with younger age at FSGS onset, with the highest in infant, higher than child, and less in adults. Inheritance patterns span the whole gamut of patterns of genetic inheritance, so really any of them are possible. So over 50 genes have been associated with FSGS. I give you a partial list below. Some genes of these may impair renal development, causing a post-adaptive FSGS. So first column is the slit diaphragm proteins, nephrin and potosin, some of the first ones to be identified many years ago. Others are cytoskeleton related, as shown here, either within the cytoskeleton itself or downstream of it, or binding to the cytoskeleton or binding to external factors. Polarity related, CRB2, extracellular matrix, Ca4a in particular, the endosome protein, CLCN5, mitochondrial proteins, including these COQ protein variants. And this is so important because therapy in many cases can be benefited by ubiquinone available at Costco and other outlets near you. And so it's certainly worth making a diagnosis of any of these, but certainly ones for which therapy is readily available. And of course, the other reason for genetic diagnosis is helping the family figure out, are there other individuals in the family who need to be tested? Are there issues about having future children? And then lastly, the adaptive protein in the podocyte, the CD2AP. So here's an example of onset age and inheritance pattern. This could be done for all 50 genes, but I didn't have room on the slide. So in an infant or child, you'd be thinking about NPHS1 or 2 or the others listed there. These are autosomal recessive. Notice that the autosomal dominant are much less common in children, except for alpha-actinin and 4. There is this X-linked molecule, NXF5, and then various mitochondrial proteins as listed. Whereas in the adolescent or adult, those autosomal recessive mutations are much less common, and instead the common ones are TRPC6 and inverted formin. Well, this is interesting to know, but as I say, increasingly as an approach, people are going to be using next generation sequencing and looking for variants that aren't expected or even as novel variants. The main downside is that there's a certain computational and informatics burden to looking through the whole genome, as well as finding unexpected variants in a disease that has maybe not been diagnosed or a future risk that then involves in genetic counseling. So there is complexity to doing whole exome or whole genome studies, but I think it probably is the way to go. So therapy for genetic FSGS, most FSGS genetic cases are similar to adaptive, but as I mentioned, most mitochondrial mutations respond to COQ10, so certainly a diagnosis worth making. So who in your patient group would have the highest likelihood of a genetic cause? Well, it would be age of onset, with younger being more likely than older. Certainly an FSGS family history is helpful, but it's most useful for autosomal dominant or geographically or socially isolated communities where there may be familial relationships among parents, and so autosomal recessive may be seen without a family, may be seen in that setting. So non-renal features are important to know about and are but may be absent. Glucocorticoid resistance certainly makes you think about genetic causes, although there are a couple of genes where glucocorticoid sensitivity is seen. Maternal genome variants, of course, involve maternal inheritance, so a characterization in a family of FSGS linked to females would suggest this. Now, APOL-1, which I'll be talking about extensively in a minute, is an outlier, as most individuals, probably 80%, that's my estimate. It's not firmly grounded, I'll be the first to say, with 2 risk alleles will never develop kidney disease. So this is definitely a low penetrance syndrome. So how do you approach it as a renal pathologist counseling your nephrologist? Well, in an affected family member with a known genetic variant, then clearly do a test just for that variant. In mitochondrial diseases, you might wish to just focus on the mitochondrial genome. But an autosomal variant, you do need to sequence the whole nuclear genome. And as I say, with next generation sequencing, it's probably no more expensive to do that than to do whole exome. So many commercial labs will start with a non-clinical grade sequencing and then confirm likely pathogenic variants with a new blood sample and clinical grade sequencing for that particular region where 1 or more variants has been found. And that's available from commercial laboratories as well. Turning now to viral FSGS, there are 3 viruses that I'd like to talk about. So HIV-1, as you know, is associated with APOL-1 high-risk status that is African ancestry. Collapsing glomerulopathy is the prototypical form of HIV-associated nephropathy, but it can also be not otherwise specified. And therapy involves, if the patient is not on or not taking consistently, antiretroviral combination therapy. The so-called, we used to be called HART, now it's called ART, antiviral therapy. Parvovirus B19 arises in immunosuppression, for example, renal transplant. In the acute phase, it manifests as proliferative glomerulonephritis. In a chronic phase, particularly in the immunosuppressed host, where the immune system does not effectively suppress viral replication, it then can lead to FSGS and collapsing glomerulopathy. Unfortunately, there are no therapies that I'm aware of at the moment. In an immunocompetent host, for example, say a bone marrow transplant who recovers their immune system, it will resolve spontaneously, but that may not always be what happens. Immunocompetence may not be restored. And then lastly, CMV, a common infection in the setting of immunosuppression, for example, renal transplant, other bone marrow transplants also, manifests as mesangial cell and glomerular cell infection and rarely collapsing glomerulopathy. Fortunately, we do have an effective therapy, as you know, canciclovir. So for all of these, reducing immunosuppression with medication, if possible, is worth doing. And then treating the viral infection, as I've mentioned, is also clearly the way to go. So the 5th of these 6 categories I'll be talking about, medication-associated FSGS. Just checking on time here. I think I'm good on time. So Pemdronate, a bone-acting agent, is associated in high doses with FSGS. The mechanism is not known. It's an interesting area to look into, particularly presents with collapsing FSGS. Interferon increases APOL-1 gene expression, and so pretty much all of the patients that I know about with interferon-associated FSGS have APOL-1 high-risk status. Lithium is a tubular toxin, and therefore it causes nephron dropout, leading to reduced nephron numbers, leading to a post-adaptive form of FSGS. But there's a second form that I think is not well understood, and again, is something that is worthy of pursuit in patients and pathologists who have these patients, an MCD-like presentation, heavy proteinuria, low serum albumin, that's clearly very different from the post-adaptive form. And I personally don't know anything about it. Maybe somebody will enlighten me. But I think we need to know more. Or I see 2 things in the chat. Am I supposed to be doing anything? Okay, so there are comments. Oh, could I speak a bit slower? Sorry about that. Yes, I have been accused of speaking too fast, so thank you for the reminder. All right, where did we get down to? I've now lost the train. I think we were talking about heroin, pretty much has disappeared because it appears to be acting largely through HIV infection and also potentially bacteria and fungus if the needles are quite contaminated. Sirolimus acts by reducing VEGF, vascular endothelial growth factor, and causes a not otherwise specified form of FSGS. All right. APOL-1 Fsgs. This is a longer topic. It's the final of the categories and was one I was particularly asked to talk about. So APOL-1 is a minor protein constituent of the HDL particle. Expression is driven by interferon alpha, which makes sense for this protein, which is part of the innate immune system. In the parasites, particularly trypanosomes, in our blood take up HDL, where they find APOL-1 lying in wait, and it kills this via this BH3 domain, which binds proteins that regulate autophagy. It has 7 exons. It's approximately 400 amino acids. There are different splice isoforms. And you can see the structure there, the pore-forming domain that causes the killing of the trypanosome, the membrane addressing domain, and the SRA that interacts with the serum resistance antigen of the trypanosome that allows it to enter. So importantly, APOL-1 can manifest clinically as at least 4 different mechanistic forms, and your therapy might initially be targeted to the form that it is manifesting, while at some point anti-APOL-1 therapy would be started. It's not commercially available at this point. So primary FSGS, many of these patients can be glucocorticoid responsive, so it's a genetic disease that steroids have a role. And it can recur after kidney transplant, both of which sort of suggest a circulating factor. Certainly recurrence after transplant would support the idea that APOL-1 is participating. But APOL-1 variants can also cause what appear to be adaptive glomerular processes. For example, sickle cell, where the nephropathy is thought to be to chronic sickling in the glomerular loops, leading to reduced filtration. And this is one form in which APOL-1 also increases the risk for kidney disease in sicklers. Also, CKD associated with prematurity. This was shown in both the CKID and the Neptune cohorts, such that premature children, as they become older and their need for glomerular filtration rises, are less able to provide that, and so they have a hyperfiltration through reduced glomerular numbers kind of process. Viral FSGS is perhaps one of the most striking places where APOL-1 acts. The odds ratio in the United States is 29 that an individual with collapsing with viral FSGS, particularly the collapsing variant, has 2 risk alleles, and the odds ratio is 89 in South Africa. Probably not mathematically different or clinically different between these two, but very high. Also, drug-associated FSGS due to interferon therapy, which of course makes sense because interferon activates APOL-1 gene transcription. And if you are unfortunate enough to have 2 copies of the APOL-1 gene, the risk copies, then having more of that protein will be deleterious. All right, what are the implications of the observation that different factors contribute to APOL-1 disease? So here I'm thinking about a fertile soil hypothesis, it might be called, where podocytes and perhaps vascular cells as well are susceptible to injury when APOL-1 variants alter endolysosomal function or inflammatory signaling or some of their processes. Again, susceptible to injury, but it takes a second actor to arise to induce disease. And this would explain the fact that perhaps, and this is an estimate, but only 20% of individuals with 2 APOL-1 risk alleles will get kidney disease. So what is that second factor for primary FSGS? It would be certainly interferon, which we know increases APOL-1 expression, but perhaps other cytokines interact with APOL-1. So adaptive FSGS, as seen as sickle cell or prematurity, would involve a glomerular load capacity imbalance. That is, the system is looking for an increased filtration, and APOL-1 in some way impairs the ability to generate that due to defects in podocytes. With HIV-1, there may be direct infection of podocytes, and the accessory proteins VPR and NEF have been implicated in that, in HIV nephropathy. And of course, as I mentioned, interferon turning on HIV would cause more expression of these proteins. What I'm calling here arterionephrosclerosis, or others might call hypertension attributed or misattributed kidney disease, What's the interaction here? Somehow APOL1 is contributing, it appears, to increasing blood pressure, or may bring altering lipids, or maybe promoting innate immune inflammation. I think this relationship between the pathologic syndrome of arterial nephrosclerosis and the role of APOL1 is an area that's we really need to know more about. And with regard to lupus, interferon may be the interaction here. And unfortunately, I continue to have problems seeing the bottom of my slide. So I was something about type 2 diabetes, but I cannot see it. I'll try one more time to, no, I can't get rid of it. Okay, so the APOL1 deceased donor transplant story. This was a paper led by Barry Friedman. Collected data from 55 US centers, 675 kidney transplants. And as you can see, that the duration and time of allograft survival was shorter for the APOL1-2 risk alleles, that is the red line, and that the hazard ratio for allograft loss was 2.3 with donor genotypes. Now, this is interesting. We understand that I'm sorry, this makes sense. The donor kidney is coming in. If it has 2 risk alleles, it will be more susceptible to injury. And certainly in a post-transplant setting, there are multiple potential injuries: acute kidney injury, medications, the fact that it's a single kidney trying to cope with a full-size person might cause a stress. So that kind of makes sense. The recipient genotype is still has been studied. And it turns out that it does not have an effect, as you can see here, which again makes sense because we believe that the risk for APOL1 kidney disease travels with the kidney. And so an individual who is a high risk but receives a kidney the risk will travel with the kidney. So those 2 risk alleles and 0-1 risk alleles are referred, as I say, to recipient genotype. So summary of key clinical features of APOL1 kidney disease: it manifests as FSGS, as collapsing glomerulopathy, as arterial nephrosclerosis, otherwise known as focal global glomerulosclerosis. It probably presents as primary FSGS and as adaptive FSGS, depending on what has challenged the podocyte. The collapsing variant is particularly associated with APOL1. Interferon is a driver of APOL1 gene expression, and so conditions associated with interferon are a place to look for APOL1 nephropathy. Compared to other forms of FSGS, it tends to be more advanced at presentation and faster progression. And so once we make that diagnosis, the time to intervene is short, and it certainly should send an alarm signal that it may only be 6 months, a year, or 2 years in many cases before somebody has progressed to a point where therapy is unlikely to be successful. So it should be an alarm signal to try to intervene if a drug is not working. I suggest try it for 2 or 3 months or whatever you feel is appropriate, and then move on to something else. It is interesting that in APOL1 high-risk cases, response to steroids, cyclosporin, and mycophenolate appears to be similar to other FSGS cases in terms of proteinuria response, but nonetheless, many of these patients will progress for whatever reason. And kidney transplant 2 risk allele genotype is associated with worse outcomes, suggesting now that we should be genotyping, and I think most programs are, all of their transplant donors, not assuming anything about ethnicity. And if somebody is identified with 2 risk alleles, counseling them that they should strongly consider not to proceed. Of course, a parent wanting to donate to a child may decide that that's something they still want to do, but clearly there needs to be counseling. So a summary of 7 cell activation pathways that are triggered by APOL1 risk variants. At the top, interferon, either from a chronic viral infection such as HIV, or when given therapeutically, increases APOL1 gene expression. And then that triggers some of the pathways shown below, going clockwise: altered endolysosomal trafficking, compromised mitochondrial function, activated inflammasomes, promoting SUPAR activation of alpha V beta 3 integrin, something Jochen Reiser has championed, activating protein kinase R, which is an antiviral mechanism that shuts down protein synthesis, something that we have characterized, And obviously shutting down protein synthesis is good in a virally infected cell, but not in a podocyte. Opening plasma membrane channels, and lastly, and most recently, preventing APOL-3, a cousin that's just really emerged, and its ability to control the actomyosin cytoskeleton. So does increased APOL-1 expression trigger renal disease? I think there's evidence on both sides. The evidence for is that interferon therapy increases APOL-1 expression, I should say in vitro, and as well as in vivo. The evidence against is that circulating APOL-1 levels are similar in HIV subjects with poor control with and without HIVAN. And then in but I will say we don't necessarily know that the circulating levels are tracking what's going on in the podocyte. In the Neptune study, they got directly at that APOL-1 Fsgs subjects had similar APOL-1 expression levels in glomeruli and in the tubulointerstitium to other subjects at the time of biopsy. All right, so if it's not elevated in the circulation, if it's not elevated in the kidney at one point in time, could there be pulses of interferon that occur with viral infection or other stimuli? And if we just take a one point in time, we may not be able to see that. And again, there, as I say, the limitations for assessment at a single time point. So this is a somewhat theoretical slide. I would definitely acknowledge that it needs to be taken cautiously. We put this out a number of years ago. We attempted to estimate the lifetime risk of HIVAN in a setting with 2 risk alleles and in those without ART, and came up with a 50% incidence. And we looked at the rate of FSGS and estimated that the rate in a 2 risk allele individual of having the rate of an individual was about 4%. 4% risk again for end-stage kidney disease. So how about response to therapy? Well, it turns out response to therapies is similar despite the APOL-1 status. So really we should be using these same therapies in the APOL-1 positive patient, 2 risk allele patient with FSGS, with the one caveat that we know it tends to progress quickly. And so I would advocate using each of these for a fairly short period of time. If there is no response after what the nephrologists feel is an appropriate duration, then moving on to the next drug. And also counseling the patient that we may only have a couple of years, but to try to find a drug that can put you into remission. And it's really important to take the medicine. If there are side effects, let me know so we can move on to another medication. Well, there are roles for APOL-1 in other renal diseases, lupus nephritis, where the APOL-1 high-risk status was seen in 25% of ESKD cases and 12% in those who did not reach ESKD, suggesting that this is an accelerant in lupus as it is in other diseases. Also a role in preeclampsia. This first came to light in a study. I don't think I put the individual here. I think there's Leslie Brueggemann, NPHS1 promoter APOL-1 transgenic mice. Interesting, the G0 alone, APOL-1 is not normally a protein in mice. So APOL-1 G0 alone prompted preeclampsia, and that was more so in APOL-1 G2 mice. In humans, fetal but not maternal genotype is associated with preeclampsia, with an odds ratio very similar in 2 different studies, 1.8, 1.9 at Einstein and at UT Southwestern. So again, something that probably, I'm not sure our obstetricians know about this, and I think we need to consider whether knowing the mother's genotype would be useful to potentially predict this very dangerous complication. So in conclusion of the primary glomerular syndromes, FSGS is the most common and the most likely to progress. It comprises 6 distinct classes of subsyndromes, as I've laid out. It'll take nephrologists, nephropathologists, and geneticists working together to solve the puzzle that each patient presents. Different forms of these 6 forms I've talked about will require different therapies. And fortunately, novel therapeutics, because many companies have realized this is an important area that they can contribute to, are emerging that will enable targeted therapy. So with that, I'd like to close. Just thank my long-term collaborator, Sherry Winkler, on the left, and my current and past lab members on the right, particularly staff scientist working with me, Jürgen Hyman. And with that, I'll just say here's our NIH campus in Bethesda, Maryland. 240 beds, 1,200 investigators, 4,000 fellows. And with that, I'll stop and be happy to take your questions. Thank you for your attention.
Great. Thank you very much, Dr. Kopp, for that excellent update on FSGS and APOL-1 from a more clinical perspective. I think it provided a very nice supplementary information to Dr. Wien's talk from a few weeks ago, which was focused more on the pathology side of things. So yeah, thanks again for doing this. We do have a few questions that have come through on both the chat and the Q&A. So I'll just start going through those, maybe start with the ones in the chat that everyone can see. So Dr. Haas has asked, or he's commented that the use of IgG removal as a potential therapy for recurrent FSGS suggests that IDS or imlifidase may be useful for treatment of recurrent FSGS. Do you know if anyone has looked into this?
I'm just looking. I didn't quite catch the name of the drugs.
Yeah, I don't know if I'm. So it's
is in the chat.
Yeah, it's in the chat. Yeah. So.
I know what you mean. Yes, this is the. I thought about putting that in. This is, I think, the globifin column, if I remember correctly, and I think that's a very appealing approach to try that in these patients. To remove selectively IgG, so it doesn't completely. It doesn't deplete the immune system as much. So I agree. To my knowledge, I think there is interest from that company in looking into this. I don't remember exactly where that stands.
Great, thanks.
And I do apologize again for speaking slowly. I usually say I can't help it. I'm from New York, and that's the way I am, as quickly as I can.
No worries. Okay, Dr. Randawa has asked, are there any biopsy findings that can help the pathologist think about APOL1 variant? So I think you did cover this a little bit, but yeah.
Right, so I would say certainly collapsing glomerulopathy, knowing that somebody has African-American ancestry, but I stress that this can occur in people with any self-declared ancestry. Certainly somebody who's Hispanic or European-American may have it. So I would say collapsing glomerulopathy, marked podocyte changes would be two that come to my mind, and if somebody else has other thoughts, I would welcome those.
No, I would agree. Okay, Dr. Howell has asked.
I'm sorry, one other thing would be, I should say rapid progression. So somebody who, comes in for a routine screening and has a creatinine of 2 or 1.5, and 6 months later it's 3, it may be too late, but that kind of a trajectory makes me think of APOL1. I'm sorry to interrupt.
Yeah, no worries. Okay, Dr. Howell has asked, are 2 risk allele live kidney donors, in addition to the recipients of such kidneys, at greater risk of developing FSGS post-donation?
Absolutely, and I thought I mentioned that, but if I didn't, that was an error. Yes,
I think you did.
2 living donors, 2 risk allele living donors are definitely at increased risk of kidney progression. Sometimes at that point, the people are reluctant to do a biopsy because, of course, they only have 1 kidney. But I would say those individuals we must really counsel them. Is this something you want to do? Provide them with the most current numbers as to the risk. It's in a couple of the papers, but they aren't large papers. And certainly some people will say, I'll take the risk. This is my child and I want them to have a normal life and this is the best kidney for them. But they clearly need to be counseled. Yep.
Great, thanks. Another question from Dr. Randawa. Some studies stress focal global sclerosis as being more typical of APOL1 rather than focal segmental sclerosis. Can you think of any mechanistic reason for this?
Well, when I hear about that, I think the following, and it may be off base, that they have rapidly progressed. So that because this is a rapidly progressing form of FSGS in many cases. But if I already hear pathologists say, no, we can show that for a similar GFR, which of course is tricky, that there's more global sclerosis than in other cases, then I would have to rethink that. And I think that would be good to document. If it's in the literature, then I've missed it.
Okay. There's a question you made. Yeah, I'm not sure if you can see this one, but somebody's asking, I think they're referring.
Is this from Mohammed?
There's a question from Rita about IHC, and I think they're referring to APOL-1 IHC. So there is IHC available, but can it be used for practical use for identification of these cases? I don't believe so, but do you know anything about?
The antibodies are not specific for the particular variants to my knowledge. Remember, these are very small variants. One is a single codon change. The other is a 2 codon deletion. I suppose in theory you could develop an antibody, but to me, it's not been done. And it should be possible to get blood from the patient for the genotyping, because in fact, you do need to obtain, I think, consent to do genetic studies. So the person would have to come back, give consent, and you might as well draw blood and do it that way. But there may be a compelling argument that I'm missing, including, I suppose, past studies of where the patient is not here. So it can be done from paraffin sections, yes.
Just a comment from Jeanette that I think with regards to the discussion around the features suggestive of APOL-1 nephropathy, that the Arcana group, Chris Larson and others have suggested microcysts as being associated. I mean, certainly that feature is seen in HIVAN. So I guess, yeah, along with the spectrum of collapsing glomerulopathy, but yeah, just another comment from Jeanette. I'm not sure if that's been specifically shown in the literature with regards to
that's a good point. I sort of had missed that. So thank you for educating me about that.
Yeah, another comment from Rita regarding the focal global glomerulosclerosis and being suggestive of APOL. And obviously that's a difficult thing for us to determine or to associate with APOL-1 as pathologists, because we see that in all cases, and differentiating from age-related global sclerosis is an issue. Yeah, I'll maybe move over to the Q&A now, because we have a few good questions in there, and then come back to the chat if we have time. So a couple of questions regarding the association between APOL-1 and COVID and FSGS and collapsing glomerulopathy. Can you comment on that association?
That's an excellent question, Cindy, and I should have included that, I realize, in my tables. Yes, I think both are probably acting through interferon as chronic infections. And so those are important to include. Agreed.
A question, can APOL-1 induce minimal change disease nephropathy? Or could this just be associated with severe hypertension?
So with regard to the first, there's always the question is it unsampled FSGS? I guess the key would be if there were cases of 2 risk allele individuals who had a classic non-progressing course of proteinuric disease over many years, it would argue that it could be. I'm not aware that that's been reported, but there may be something out there. And could it be associated with severe hypertension? I think mainly through the extent of the renal damage. Somebody clearly with chronic kidney disease, in some cases, will have severe malignant hypertension.
Yeah. Okay, question from Mohammed, which sounds like maybe a patient, which is good to see some involvement from our patient partners. He says, in my case, where genetic testing is not done routinely for lack of resources, or perhaps this is a clinician that is in this situation. So I guess in the situation where genetic testing is not done routinely for lack of resources, how do we proceed with a patient who has FSGS resistant to glucocorticoids and doesn't respond to CNI within 6 months? Does rituximab or other treatments have a role here?
I would say at that point, I would probably switch to mycophenolate as the third oral agent. I think rituximab is a possibility, but in my experience, people who are glucocorticoid resistant tend to be resistant to rituximab as well. So I prefer mycophenolate as the third agent, but rituximab could be a last-ditch effort. And of course, another point will be always, this brings up the idea that if somebody isn't responding, it's so important to move on after whatever period of time you feel has been appropriate, 3 months, 4 months, 6 months, perhaps at the outside. If there's been no budging of the proteinuria, not even what I would call a limited remission, that is a 50% fall in proteinuria, but not getting subnephrotic, not getting below 2 grams per gram, then move on to something else, because some of these patients will be rapid progressors, And if it takes a long time to move between therapies, you'll never get to try one that might have worked.
Thank you. Here's a question from, or comment to question from Nassim. I often hear from my nephrology colleagues that post-adaptive FSGS should not be the top differential in the setting of diffuse podocyte effacement, but I believe in an older obese hypertensive individual with preserved serum albumin above 3, post-adaptive is a likely cause despite diffuse effacement. Do you have any thoughts on this?
Yeah, I mean, I don't have any great wisdom here. I think it's a question of looking at the totality of the evidence, looking at all the, the different features. Sometimes there are these cases that don't fall into the nice cubicles we've assigned to them. And I don't have any great wisdom besides looking at all the different features. One issue, maybe the albumin is not normal, but it's fallen substantially if there had been a value before. Maybe it's fallen from 3.5 to 2.1 or something. So it really depends upon looking as much of the data as you can. If you're in total doubt and the GFR is relatively preserved, you might go down the post-adaptive route first because those medications are less toxic. On the other hand, if the GFR is already low, you might say, I don't have a lot of chances and I'm going to go the glucocorticoid route first. But clearly, these are complex situations that the nephrologist on the spot has to decide.
Thank you. There's a question from Chanaka that I don't completely understand regarding the association between APOL-1 and diabetic nephropathy or diabetic kidney disease. Did you want to comment on that association at all, or are you able to comment on that?
This has come up before. I don't think there's an increased rate of other glomerular diseases necessarily within diabetes, but clearly a diabetic can have a second disease, membranous FSGS, minimal change. Diagnosing minimal change in the setting of diabetic nephropathy is going to be quite a challenge. But I would say somebody who has 8 grams of proteinuria and is a diabetic and maybe has diabetic eye changes may well have a second disorder with complete foot process effacement suggesting minimal change. Sometimes it's easier to sort out these dual disease situations than others. I do acknowledge that.
Yeah, for sure. One other comment from Dr. Haas. One disease that was not mentioned as having an association with APOL-1 was IgA nephropathy. Yet segmental glomerulosclerosis and IgA nephropathy is associated with worse clinical outcomes. Furthermore, Ian Roberts and colleagues have shown that IgA nephropathy with evidence of podocyte hyperplasia may be steroid responsive. Has APOL-1 been studied in IgA that you're aware of?
I'm not. Of course, it tends to occur in very different ethnic populations, but there may be individuals where APOL-1 high-risk status overlaps with IgA, and I guess you would go to countries where IgA, and say in Africa, this is beyond my knowledge, I have to say, where there might be a substantial amount of IgA nephropathy, and that would be an interesting question to look at. That's something I haven't thought about. Good question.
Mm-hmm. Okay, I'll just address these last 2 questions and then we'll maybe close at that point. So another question from Rita. So Alports as a cause for non-responding FSGS, any morphologic clues for that? So I mean, I would say from the pathologist perspective, the typical glomerular basement membrane changes would be the most obvious clue. I'm not sure if you can add anything from your side, Dr. Kopp.
Yeah, no, I agree. And I just would add also, if there is a family history of kidney disease, you look at that carefully. Of course, it can be a family history of kidney disease in APOL-1. It tends to be, doesn't follow any classic pattern of dominant, recessive, sex-linked. These are things that you have to put all the pieces together, and sometimes pieces are missing from the puzzle. And so in that case, you could certainly do the genetic testing.
Mm-hmm. Okay, and the last question, has anyone looked into patients with single APOL-1 gene variant heterozygous?
Yes, yes. And if I didn't mention that, that was an important omission. There is a setting, at the moment, the one is HIV in sub-Saharan Africa, where a single risk allele is enough to statistically increase the risk for kidney disease. So I think what it's telling us that there's a spectrum, and if you have a chronic HIV infection and have very high levels of interferon, then even single risk allele seems to be sufficient to drive kidney damage. And I suspect the other situations where we would see that, potentially in untreated lupus or other settings of high interferon, where a single risk allele may be enough to provide the genomic substrate for of the abnormal protein to have a phenotype.
All right, thanks for addressing all of those questions, and thanks again for the excellent presentation, Dr. Kopp. It was a real pleasure to have you with us today. So I forgot to mention at the beginning that a recording of this presentation will be available on the RPS website within the next week or so. So yeah, please watch for that. And yeah, our next session in this series will be Dr. Matt Sampson from Boston giving a talk on the genetics of podocytopathies, emerging technologies and novel insights, and that is in 2 weeks' time on December 2nd, same time. So we'll hope to see you all there. Thanks again, everyone.
Thank you so much.